Thank you, Jim. Appreciate that. And thanks everyone for taking the time to join us for this webinar here today. I know everyone is super busy, and I hope this information is helpful to you and the clients that you serve. This is a webinar on switch assessment, but with a particular focus on clients who are not very engaged. So you're working with a client. I happen to work with a lot of children, and so I'm going to say kids a lot, but this information really applies to all ages. You need to figure out where to put a switch, what type of switch maybe to use, but this client is just not playing along too well. What do you do? So that's what we're going to talk about today, and we should have plenty of time for questions and discussion as well. I know this group always has a lot of great ideas. I'm Michelle Lang. I'm an occupational therapist in the Denver, Colorado area, and I do switch assessment as a part of my job a lot of the time. So we're going to be talking about the client who's not engaged. You bring out that switch and maybe the client just doesn't seem real interested in activating it. So we need to determine why. Why isn't this client engaged? How do we determine how to engage them, how to motivate this client? We're going to talk about some specific interventions and throw in a few case studies as we go along. So who is the client who's not engaged? Well, this might be a client who you say, hey, press this cool switch that's in front of you or wherever you're able to access it, and they don't respond. If they do respond, this might be a client who tends to bang the switch, pull on that tempting cord, or even throw the switch across the room. And overall, this is usually a client who doesn't see the switch as a tool. They see it more as the task. So they're engaging, if they are at all, with the switch itself rather than what the switch is connected to. Our job is to help the client move to realizing that the switch is simply a tool and they need to attend to what it is controlling, whether that's an app, whether it's a battery operated toy, whether it's a communication device. But probably with this client who's not engaged, we're going to start with pretty simple activities to help them develop that engagement and the ability to see this as a tool. So, who is this client? Well, the client may have significant developmental delays, perhaps significant cognitive limitations. Sometimes this client may have limited vision, and that can add another layer to make this more difficult because now we have to come up with a task to help this client see the switch as a tool. And again, we're assuming here that the switch is their best access method, or at least a good place to start, but we want them to engage, and we may not be able to do so from a visual standpoint. We need to bring in auditory and tactile and such. It may be this client has a lower level of alertness. This can be also due to cognitive involvement, such as a brain injury. It might be the client doesn't trust you, that white coat syndrome. I don't think I've ever had to wear a white coat, but it doesn't matter. A lot of our clients have had a lot of very negative experiences with healthcare professionals. And so it's important that we create a very welcoming and safe environment. And there's also clients that are over therapized. Boy, these are difficult situations to work in, where the client sees what we're asking them to do is something you're making me do. Yet another therapist saying, you got to do this. And again, not seeing the switch as a tool, but rather as a task. You're making me hit the switch. Okay, fine, I'll hit the switch. But I don't see the point of doing so. So, how does this impact access? Well, in a devastating way sometimes. If the client won't engage in the activity, then it's really hard to figure out where to put a switch and what type of switch to use because we can't entice the client to hit the switch in the first place. If we don't determine the optimal switch type and site, then the client may not be able to optimally use their assistive technology. And training switch use can also be very challenging. So here are some things we need to keep in mind. We need to first establish rapport. Now, that's therapy 101. I know all of us have different roles on the team, but it's very, very important that we establish some type of relationship with the client, often with the caregivers as well, that there's a connection there, there's a level of trust there. And that can take a while with some of our clients. We then have to determine motivators, and I really rely on caregivers quite a bit to help me with this as well. And then from there, we can start determining likely switch types, likely switch sites. So I really do want this to be helpful to you, not just something to do with an hour of your time. So think about a client you're working with where perhaps this client is challenging in this way. It's hard to get them engaged. And as we move through this material, jot down some notes, things that might be helpful. Give them a try. Feel free to let me know how it works or if you've come up with some new ideas as a result. So let's start with establishing rapport. All about the relationship here. So we want the client to feel comfortable. You know, I've been a therapist now for, gosh, 35 years, and I've mostly worked with children. My main goal when I'm meeting a child for the first time and their very nervous parents is for everyone to feel comfortable because my priority is I want this little person to do their very, very best for me. They're not going to do their very best if they're terrified of me or if they're worried that they won't do well, they won't pass some sort of test. So, my goal isn't to bring out a lab coat and a clipboard or use a bunch of intimidating acronyms. I want everyone to be comfortable. So I get down to the client's level. I use eye contact and I really try to touch my client. So physically, I will reach out, put a hand on my client. Not usually light touch. A lot of our clients are have sensory issues, and that light touch can feel kind of yucky. So kind of a firm touch and say, "Hi, how you doing?" Really try to connect with that client. If the client doesn't trust me, and there's a good chance if they've just met me, they don't trust anyone who's new. So try not to take that personally. I need to reassure them. I will literally say to a client, we're just going to play today. This isn't a test. We're not going to do anything yucky. I'm not allowed to do yucky stuff with clients. We're just going to play today. We're just going to hang out. So, whether they believe me or not, I do try to reassure this client. For clients that I believe are over therapized, they're like, oh no, another therapist. I have to do whatever they want me to do. And then hopefully I'm out of here. Then I might forget typical therapy, throw it out the window, and focus again on establishing that rapport. Now, you might think, wait a minute, how in the heck am I going to document? I just hung out and talked about the latest kid movie that's out there with my client. How do I justify charging for that? If we don't establish rapport successfully, we're not going to be successful in our other therapy goals. And I believe this is a valid step of the process. With some clients, this might take just a few minutes. With other clients, it might take a few sessions for them to calm down and you to be able to really work with them. From there, we need to determine what motivates this individual. We all have different motivators. I have to motivate myself, as most of us as adults do. Maybe I have to do something I don't really like to do, like clean my bathrooms. I might motivate myself by listening to some of my favorite tunes while I'm cleaning those bathrooms, or reward myself with some chocolate when I'm done. So it's important to ask caregivers, team members, even the client as appropriate. You may not have that connection yet. They may not have a way of communicating this readily to you, but find out what they like, whatever it is. Many of our clients, particularly clients that are hard to engage, are really motivated by music and sensory tasks. Now, some of those sensory tasks might throw them over the edge. So it's important to know if there's certain things that are more of a negative stimuli than a positive one for this client. Other things that can really engage clients are jokes. Really lame dad jokes work well. Toy cars, maybe videos on an iPad, balls, bubbles, that sort of thing. This young lady here has Rett syndrome, and she is now using eye gaze to a limited extent and accessing communication. But it was hard to initially engage her, and she was very excited about activating some apps on an iPad. iPads are shiny, they're very exciting, and there's a lot of music in these apps. So we started off with switches. When she hit the switch, something really fun happened, like with these 5 little bears on a wall. Then we can move on to finding a switch site. So once the client's feeling comfortable, you know what's motivating for them, you can start bringing in a switch. So this may not be the first appointment at all. And then when the client hits the switch, this is important for all of our clients, but particularly a client that's hard to engage. It's really important to make sure they get a fantastic, meaningful, huge response and that that's consistent so that we can train them that, wow, every time I hit this switch, something great happens. Maybe it's worth my while. The switch doesn't even have to be plugged into something. Maybe for this child, you've given them a choice of, do you want mommy to kiss you on your face or tickle you? The switch doesn't have to be plugged into anything. When the client activates the switch, say, hey, mom, get in there. They chose kiss me on my face, and have mom really make a big deal about kissing them all over their face so that it's motivating for that client. It might be this client is motivated by something that's harder to capture on with a switch operated toy or with an app on an iPad, for example. So this is a lot easier to really flesh out through some examples. So we're going to talk about several case examples here. And I want to encourage you to, if you have a question or a comment, feel free to put that in that Q&A box anytime you want. If I don't answer it right away, it's because I'm waiting for a good stopping point, but I don't want you to forget. If you're like me, I'll forget it by the end of the session. So feel free to put them in whenever you would like. We're going to start with Alexi. Alexi in this picture here is 10 years old, and he was about 3 years post a traumatic brain injury as a result of a motor vehicle accident. He has very low vision, and his hands at the time were very, very hypersensitive. So any contact with his hands was a negative stimulation that he really didn't like. So when I first met Alexi, the goal of the appointment was actually a communication evaluation. Now, literally, because of a scheduling mess up, I ended up seeing him by myself the first time, which was fine because Alexi didn't have any access. So it was going to be really hard to figure out a best way for him to communicate. So we downshifted to finding a switch site, but it took a long time. First, I needed to establish rapport. Alexi became agitated very easily. That's common with someone who has a traumatic brain injury, and it was very hard to calm him down. One of the triggers for his anxiety, his agitation, was going to any medical appointment. He had no way of knowing that I wasn't going to do anything yucky during this appointment. All he knew was, oh, great, I'm pulling up to one of these buildings. Someone's wheeling me in. This is not going to be good. I tried to reassure him that there were no ouchies involved. I wasn't going to do anything yucky to him, but he was still very upset. He didn't trust me. He didn't have any reason to trust me. So I asked his caregivers, what helps Alexi calm down? Is there anything that consistently helps him come down from this agitation? Again, his ability to self-calm due to his brain injury was very limited. Well, I found out that he really loved Broadway musical scores, those really big sweeping musical scores. But he didn't like it if there were any lyrics. So they had a collection of these, and they could play them to help him calm down. As soon as that music started, he went from very agitated, posturing, lots of tone, lots of movement patterns, to mush. He just melted. So we played the music to help him calm down just while we started trying to establish some rapport. It took several visits just to get him to stop screaming. He would yell the entire appointment. He started associating the appointment with, I get to just hang out, nothing yucky happens, I'm listening to this music that calms me down. So he was obviously motivated by music. So, what we started doing after several appointments, after he stopped literally screaming the entire appointment, every time he touched a switch, I would start the music. I wasn't trying to set up independent control yet. I was just trying to get him to see that he was controlling it. And this took some time. He didn't believe that he was starting the music, he thought we were. So it took some time for him to see every time that he touched the switch and we would help him do so, that the music would start. And when the music would stop, because I had it stop after a certain amount of time, we would help him hit the switch again and watch to see if he would start initiating this movement. Now, again, his hands were very hypersensitive. You could see the picture here on the left. His mom somehow managed to jam his hands into these gloves every morning, and that way he could tolerate life a little better for the rest of the day because his hands had a barrier. So I couldn't just grab his hands and help him touch a switch. He didn't like anything by his head. He would just turn towards it, jam his head into it. He also had a very strong ATNR that would drive that movement towards a switch. But he did demonstrate potential to use a switch by the lateral side of his left knee. So we placed a switch here, and I would help him push the switch while he was learning that this was how he was starting the music. So again, when he pushed the switch, I turned on the music. We eventually connected the switch to an iPad. Now, he didn't appear to realize at first that his movement had any connection to the music playing. He just thought someone turned it on because that's what had happened over the past several years. He would be upset, someone would turn on the music, he'd calm down. So it's not realistic to expect that he would understand that he had independent control for the first time after years of this pattern. It took time. But with practice, he started realizing that he was actually turning the music on. So he needed a lot of practice to develop this potential switch site. We recommended several different strategies for him to continue practicing using the switch outside of therapy. So we recommended a power link, a switch, and a universal switch mount to initially mount this until we receive some hardware on his chair. I'll go back a picture, 2 pictures here. Here we have his final mounting hardware that's on his manual wheelchair. It was actually hardware that's designed to hold a pad in this area to prevent excessive hip abduction, but we took the pad off and mounted his switch there instead. This hardware was from a company called AEL. So he was starting to practice at home and at school now, in addition to therapy. So we were starting to pick up some momentum. Eventually, we started some activities to develop scanning skills once his motor pattern was well established. And then we actually went to the communication evaluation. But the time between the first time I met Alexi and when we actually did that communication evaluation, after we had an established switch site, after we had an established motor pattern, after we had practiced developing scanning skills, was 6 months. That took a long time, one of the longest times I've ever spent with a client developing these skills. But he was eventually successful in using a speech generating device and even a power wheelchair in the future. So it took a long time. Hopefully, it was time well spent. Monica has asked, let me go to questions here. Monica has asked, what switch mounting equipment would you recommend to begin building our switch access assessment library? We have a limited budget. We all do, right? Um, wouldn't it be great if someday our boss came to us and said, we've got so much money to spend. What would you like to get? One thing I use a lot are universal switch mounts. There are several options from AbleNet, and that allows me to basically get a switch wherever I need to. I can mount it anywhere I want on a manual chair, but it also mounts well on other um, surfaces. So I can clamp it on the edge of a work surface like a desk or a table. I could connect it to the railing or headboard of a bed. I can attach it to an activity chair. So it gives me a lot of options. Now, they're kind of big and bulky, and they don't always hold their position long term. So I like to find a more permanent switch mount after that, but they're great for assessment. I use them all the time. There is another webinar in the AbleNet library on developing scanning concepts, and that might be helpful as well. And there's also one on mounting switches. So you might want to check that out as well in all your spare time. All right, I'll see if we have any more questions or comments before we move on to Tommy here. Again, I was able, fortunately, to justify all of these visits, and I was able to convince Alexi's family that it was worth coming in over and over and over again to develop these skills. But they could see that he was starting to be calmer, not be as agitated, and he was able to start controlling some things in his environment. And that was very encouraging to them as we move towards a speech generating device. Kristen has asked, how is he communicating those 6 months? Well, basically how he was communicating before that. If he was unhappy about something, he would yell. And his family had a pretty good idea of what he might need, but he certainly didn't have a lot of options. We were starting to give him some choices with the switch. Do you want A? Do you want B? And he would push the switch. So we were doing some partner assisted scanning during that time, but not a whole lot. Once we got to a point where he was understanding scanning concepts, we were able to start giving him more choices. And he really did quite well from there. Great. All right, I don't see any other questions or comments right now, so I'm going to move on to Tommy. But if you're typing and you have a question about our friend Alexi there or anything else, keep typing and we'll get to that in a little bit. Now, I do not have any pictures of Tommy. This was actually quite a while ago that I saw Tommy, but he's such a good example of a client that's not engaged and addressing this situation that I hope you'll be patient with me despite a lack of photos here. So Tommy has cerebral palsy and no vision, and he's nonverbal. He was ambulatory for very short distances. And at the time, he was 32 years old and lived in a group home. There was about 5 adult residents there. So there was a problem here, and that led Tommy to see us. Tommy had tried a lot of different switches. He had tried some basic EADLs, like some switch toys, some things connected to a power link, for example, and communication devices. But he would just bang everything. He'd pull the cords and he'd throw items. He didn't recognize any of these items as a tool, any of these items as something that would be beneficial to him. Everything was just something to explore with his hands, bang, pull, and throw. And he would get very frustrated with people who kept presenting these items to him. He had no context. So he came in for an evaluation. Well, Tommy, for us as well, pulled everything, banged everything, and threw everything we put in front of him. Everything. We weren't getting very far. He was very agitated by this new setting and by people he didn't know. So we decided that in this situation, we needed to take a field trip. We really needed to see Tommy in his familiar environment. Now, this is a while ago, and it was a little easier funding-wise to do so. Unfortunately, some of the funding limitations we have sometimes make it difficult for us to see clients in more than one environment, which is very unfortunate. This might be something you run into. Perhaps you work with someone in a school environment and you're not allowed to see them in a different environment. This is something that's important to work on as a team to meet a client's needs, because with this population, this can be an issue. So we went out to the group home, and our main goal was establishing some rapport. So we observed Tommy initially. That's all I did. And that's hard for me because it felt like I was doing nothing whatsoever. He would wander around the group home and he would occasionally approach staff. So we asked the staff, how does he indicate his needs, that he needs something? They said that he only approached them if he needed assistance in toileting or to turn on his music. They didn't think he approached them for anything else. So they would ask him, do you need to go to the bathroom? Do you want your music on? And they would watch his body language, and they were pretty good at determining what he needed help with. Sometimes they got it wrong and he would get upset. So he became frustrated very easily. He would then start yelling and screaming. Unfortunately, the other residents in the home would join in. So these very underpaid staff members in these group homes were listening to Tommy and his friends yell and scream the majority of the day. This was a situation that was becoming very dangerous and out of control. So we needed to do something. We just had to figure out what. So we decided we needed to figure out a switch type and site, if we could, for Tommy, so that he had a more appropriate means of indicating his needs. He could let people know he needed help. So we took a Big Mac and we attached it to the wall, because remember, if Tommy could grab it, he would. He would bang it, he would pull switches, he would throw it. So we permanently attached this to the wall. In a way that the staff could get it off of the wall to change the batteries. So we used some very heavy duty Velcro. Now, at first, Tommy's only goal was to bang this. He was ignoring what it said when he first hit it, and he was trying to pull this off the wall. And boy, he gave it a good try. He eventually noticed that when he was banging this, the Big Mac was saying, "I need help." The staff was instructed to immediately get by Tommy and ask what he needed. Do you need to go to the bathroom? Do you need your music on? After a while, not only did Tommy start using this, but the other clients did too. They were all walking over or wheeling over to this Big Mac and saying, "I need help." So instead of yelling or getting as frustrated, Tommy was starting to indicate that he needed help. The staff still had to ask him what he needed help with, but that was as much as he was tolerating at that time. Our second goal was to give Tommy independent means of controlling his music, because this was very motivating for him. It was very calming for him, and he would get very agitated if he couldn't start his music quickly. He was relying on others to start his music all this time. He only liked one radio station. He would get very upset if someone changed to this. And if he was given the opportunity, he turned up the volume so loud that the neighbors had called the police. So we decided we did not need to give him the choice of changing music, like changing an album or changing a song, and we didn't want him to have volume control. We chose an appropriate volume level. So he had a rather old school stereo that was sitting on a dresser in his room. So what we did at the time, since this was an older style radio, is we plugged this into a power link. The power link was out of Tommy's reach. We didn't want him throwing it, unplugging it, etc. We took an AbleNet Big Beamer wireless switch, again, no cords, and we permanently attached it to the side of his dresser because, again, he sure tried to remove this. He wanted to bang it, throw it, destroy it. Once he realized he couldn't destroy it, he noticed that it was turning on his music. Every time he pushed it, it was sending a wireless signal to the power link and it would turn on his music. Now we use this primarily in latch mode, so he could turn his music on, he could turn it off. He didn't usually turn it off. We didn't use it in time mode because this would really agitate him. He did not like this game of my music's on and now it's turned off again. He just wanted to turn it on. So now Tommy was actively using a switch in the main living area to say, I need help. And he was able to turn his music on by himself. And this was greatly reducing his agitation. Now, we really hope to explore more sophisticated communication, mobility, because he could only walk short distances, and more control for Tommy. But after trying a number of things, we decided that he, at that time, just did not have the cognitive abilities to use more sophisticated assistive technology. But he did stop yelling. He began to use this simple communication strategy of I need help, and he could turn on his music. So the staff reported that Tommy was much more relaxed and content, and as a result, everyone else was. So I sure hope that we could do more with Tommy, but it made a big difference, I hope, to his quality of life and to the people that he lived with, and it really reduced what could have become a pretty volatile situation. So any questions about Tommy before we move on to our last case study? I'll give people a chance. All right, Caitlin has said, could you please explain whether it's best to start clients with timed or latched activities? That's a great question. I think it depends what your goal is. With timed activities, I'm usually trying to entice the client to keep hitting the switch because we're trying to develop motor skills or motor pattern with hitting the switch, or maybe we're working on developing scanning concepts. I hit the switch, I wait, I need to hit the switch again at an appropriate time. That's a great way to start developing scanning concepts. With Tommy, we tried, he was not able to grasp scanning concepts, and using the timed feature was only agitating him. So we chose to use latch. Actually, most of the time, since I am working on developing switch skills, I tend to use timed. Kristen has asked, I didn't realize a power link could connect with wireless switches. Yes, it can, which is really cool. So instead of attaching a switch directly to it, you can use the beamer switch. If that's not the best switch for someone, it is a rather, big switch, and that worked well for Tommy. Remember, Tommy had no vision. We had to show him this is where the switch was and make sure it stayed in a consistent spot so he could find it and hit it. But if that's not the best switch for someone, you can also plug a different switch into a switch jack on the big beamer. So let's say you're working with someone who's in a wheelchair. The big beamer can even be behind them. You don't have to be line of sight, and you can plug in whatever switch works best for them, like a spec switch by the side of their head, and you could still utilize that wireless switch. And they do work with the power link, which is great. You can actually pair a number of different switches. So you could have different students, for example, who all have a switch that connects with the power link, and they can join in on an activity that way. So it's a nice feature. All right, any other questions or comments about Tommy or anything else before we move forward? David said, "What kind of Velcro?" So he couldn't pull it off. We used dual lock. Sometimes it's called poly lock, heavy duty Velcro. It really locks in together because the staff did need to take it off periodically to change battery. So we didn't want to screw it into anything, but Tommy was unable to get it off. And again, he sure did try. Um, Sometimes that Velcro hangs on so long and so well. If you need to get in there to take it off, you can literally take a flat slot screwdriver and kind of slide it in between those two levels and pop it off if you can't get it off either. But it works well in those situations. Depending on the client, you could, and depending on the switch, there might be holes in the rim, the flange around the switch, and you can literally screw something in and just unscrew it if you need to. Great. We'll go ahead and move on then to Rachel. So Rachel at the time, at the beginning of this case study, was 8 years old, and she has a genetic condition that results in severe developmental delays, blindness, and a lot of seizure activity. Here she is in her manual wheelchair in her favorite position. She likes to tuck her hand underneath her anterior trunk support and prop her head on her fist. And she really likes covering her mouth with her bandana. She's just all tucked in there and not very responsive when she's in that position. So here was the problem when we first met Rachel. Rachel didn't do anything all day long at school. She would put her head down, tuck her arm under her vest, and look like she was napping. She probably wasn't napping. She might have been dozing a little bit during the day, but she was very withdrawn and sub-aroused. And this does happen to some of our clients. It's important to determine whether or not the client is really napping or whether they are withdrawn and sub-aroused. Many clients who have these sub-aroused periods of time have traumatic brain injuries and might vacillate between I'm agitated or I'm sub-aroused. And we need to do what we can to find that middle ground for them where they can be more functional. It's not a functional state at either of these extremes. Oftentimes sensory input is very, very critical to arouse someone without getting to a point of agitation. Our goal was communication. How could we help Rachel to begin to communicate her needs and choices? Now, she happened to have a communication device already, but she couldn't access it. I'm not quite sure how they got funding for it, but there it was. So she had something, but she was dependent on others to use it. So the staff would grab her hand and help her hit a switch, but she never initiated the movement. She would actively pull away when someone grabbed her hand and get rather irritated. I don't really like people grabbing my hands either. And it might have been that tactily that wasn't a very pleasant experience for her and might have been driving her a little more towards that agitated side of the spectrum. Again, not a very functional state to be in. So I asked Rachel's mom what motivated her. And not a big surprise, it was sensory. Lots and lots of sensory input. Matter of fact, Rachel had a number of sensory choices that were attached to her manual chair by plastic links, such as a little ring. I'm thinking it was a little leather cuff with bells on it. So that was something she would sometimes grab, and she could hear that auditory feedback. So sensory stimulation increased her alertness level. We needed to find something to help her be more alert without getting to that agitated zone. I was concerned that Rachel was very checked out, very withdrawn within her seating system in her manual chair. And mom told me that Rachel at home didn't use her manual chair. She sat in a standard rocking chair. So she didn't need as much postural support as she appeared to. Now, most of the time, I'm seeing clients who need a great deal of postural support. So I'm typically adding in a great deal of support to help provide the stability that the client doesn't have on their own. But in the case of Rachel, when she didn't have as much postural support, she was much more animated. With the postural support, she leaned into it and checked out. Also, being in the rocking chair not only provided her adequate postural support, but it helped increase her alertness. Again, sensory, that vestibular input, that rocking back and forth, helped her to stay alert and engaged. So she would lift her head even though she did not have any functional vision, and she would be much more engaged. Well, this was very interesting information, and I knew that we needed to re-look at what was the best positioning for Rachel so that she could be as engaged as possible when she was in her manual wheelchair. Kristen has a comment here. If a student is like this and likes a sensory mat on their tray, would you start them with a sensory switch, similar texture on the switch, or stay away from this? That's a great question, and we're going to touch on that here in just a little bit, so hang tight. Now, at the time, there was a dynamic wheelchair called the Kid Rock. It is not available anymore. And Rachel, as you could see on the last part of this slide, now has dynamic seating on a more traditional tilt and space chair. But she trialed this Kid Rock chair. We wanted to know if it would work for her before we went ahead and recommended it. So when she would move at all, when she would attempt to rock like she did in a rocking chair, the system would respond to that at her hips and knees. Now, she wasn't used to a manual chair moving with her at all. She never tried to move in her manual chair. So we had to move this for her. So I literally grabbed the push handles and moved it back so that she started getting the sense that if she moved, that it would move with her, just like her rocking chair at home. So she caught on and started rocking within her manual wheelchair. It responded at the hips. She would sometimes move at her knees as well. And she was instantly more alert and engaged. Again, the Kids Rock is no longer available. It was discontinued, but we ordered her a tilt and space manual wheelchair with some dynamic components at the back, so allowing movement at her hips and at the knees. And those are from Seating Dynamics. We also wanted to figure out where could we put a switch where she could access it by herself without somebody grabbing her hand and helping her access a switch. At the time, she was able to access a jelly bean switch by the right side of her head. Now, sometimes she would check out still, and she would drop her head forward. Now, we didn't put the switch here simply so that it would encourage her to lift her head. The school was quite excited about that possibility since she spent so much time with her head forward. But when a client has no vision, it's very hard to entice them at times to keep their head upright. And this was a pretty well-established pattern for her. But she would lift her head and access this switch. If she started checking out, the people around her, whether she was at home or at school, would try to provide the appropriate sensory stimulation. We identified some things that seemed to be arousing for her until she started making choices on her communication device on her own. So the initial choices on the communication device, we kind of put aside what was already on there that she wasn't really engaging with, and we changed the choices to all sensory choices because this was most motivating for her. Again, that motivation is really, really important. And she started eventually making sensory choices so that she could decide what she wanted to engage with at that time. And that was really our goal, so that she could start realizing, right now, this sensory input is what I need to be more engaged and aroused. And that worked very well for her. This little pink box with the camo, well, kind of a leopard pattern, is actually a little speaker so that she could hear the choices on her communication device. Again, she had no vision, so she would hit the switch and hear her sensory choices. Over time, she started, stopped really lifting her head as frequently to activate the switch by the side of her head. So we started looking at other potential switch sites. We trial the switch at her right side. So if you can see my mouse here, my cursor, there's a switch on a little bar here. She actually would reach across her body with her left hand to activate it. The device, you can see pictured here, is facing outward because she doesn't see the display. But even though she can't see the display, she would try to reach out and just touch it. She enjoyed the tactile feel, but she would inadvertently select things. She thought that was hilarious because she could make it say all sorts of things. And so we tried to place the device in an area where she was less likely to inadvertently touch it. But we allowed her to access this switch. Now, it sure seems to make more sense if she's using her left hand to put the switch over on the left side of her chair, but this is where she would reach and touch the switch. So let's watch a movie. I'm sorry, this is a little dark, of her accessing the switch.
Greetings. Hi. Bye. I say bye for now. Hello.
So there she is. She does occasionally grab the cord on the switch. It hasn't been a big problem, and she's not pulling with a lot of force. So we haven't worried about that, except to try to use some wire ties, some cord ties to keep it out of her way. Now, when we're working with clients, one thing that happens is they keep changing. And so, just when you think you have something nailed down, and we thought the switch site by the side of her head would work, we needed to change that over time to by her hand. But after a while, she began to repeatedly activate this switch. So, she would bang on it. Again, just like when she was touching the screen and could make it say all sorts of funny things, she found this very, very humorous to keep hitting the switch. Basically, she was rapping and she thought that was hilarious. Now, I don't want to take away from a client something that they find entertaining, and it was something she had control over. But unfortunately, she was no longer communicating. So we had to decide what to do. So we took a switch latch and timer and placed it between the switch and the communication device. Now, usually I would use something like this with an activity like a battery operated toy or something. But in this case, we were trying to make it less motivating for her to repeatedly hit the switch. So I set this to about 5 seconds. She would activate the switch and the scan would begin. But if she quickly activated the switch again, like repeatedly, there would be no response until the elapsed amount of time, that 5 seconds. Now, did that get in the way? Well, it did at first. Because of this delay, nothing would respond for the first few selections of her scan. But it took the fun out of it. She wasn't getting that response of the rap, so to speak, of the repeated activations of the switch with the communication device. So over time, she stopped repeatedly activating the switch as a game, and she resumed using the switch as a tool for communication. So we all knew that depending on where she was in the scan, that this brief delay might sometimes get in the way if the next thing she wanted to say was at the beginning of the scan. But we put up with it for a while. We tried to keep this to a short amount of time, and it did work for Rachel in helping to defeat this perseveration, this repeated banging on the switch, allowing her to once again use her communication device for communication. Now, this is not, like with many of our more involved clients, a 100% solution. Rachel still has many withdrawn times during her day. She does have sensory choices around her. Many are attached to the chair, like you can see her plastic links and her bells here. And she does seek them out when she chooses. The dynamic seating overall has increased her alertness. So is she alert all day? No. Is she alert more than she used to be? Yes. Can she independently access a switch when she chooses to for communication, as well as other activities like on an iPad? Yes. Does she do it all the time? No. So we don't have 100% solution here, but we have a lot of improvement. So she does use her communication device, though with a limited amount of vocabulary and not as frequently as all of us would like, but she does use it. By having the switch and the mount, she can choose to engage when she's alert and ready, and it varies. She has periods of time where she's very engaged and she goes to town. And then other times where for a period of time, maybe a period of days, she's much less engaged. She also sometimes has direct touch on an iPad. You can see it on a tray here for just recreation. So in this case, I believe this one is a bubble program where she just touches it and hears lots of bubble sounds. Again, she really has no vision, but she likes hearing that auditory feedback. So she sometimes engages with an iPad with a switch, sometimes by directly touching the screen. All right. Any questions about our friend Rachel or comments that people have? And while people are talking about that, or I'm sorry, typing in questions or comments, I want to answer the last question we have. So the question was, if we are working with a client, particularly where vision is an issue, should we use a switch to try to better engage the client? Because there certainly are switches out there that light up when you touch them, that buzz, that vibrate, or have a lot of texture on them. There's even a switch out there that's a cush ball. And if you pull on it, it activates the switch. These are very tempting because they certainly can engage the client, but I do, as a rule, avoid these. The reason is the switch can be so enticing and so engaging that it becomes the task rather than the tool. And I always want to direct the client to our task is that recreational activity or that communication device or that tablet and the app that's on it, and help the client to see that the switch becomes the tool, not the end goal. These switches are so enticing and engaging. They're often more exciting than whatever you have plugged into them. And that's the main reason that I try to avoid these. But there certainly are a number of these on the market. Most of them are available from Toys for Special Children enabling devices. Thanks, Kristen. So doesn't mean you can never use them. Maybe for a client where you're having just no luck with getting this client to eventually use this as a tool, and the switch does become the task for that individual, you might want to consider it, but I really try to avoid it for that reason. I also want to encourage you, if you've been jotting down any notes throughout this, to think of that client maybe that you identified at the beginning of this course. And if there was some strategies, if you have some ideas of some things you want to try with them, jot it down so you won't forget, because after this course, you're probably going to have to jump right back into work and you'll be scratching your head later and saying, what was I thinking about? So here's our take-home message for today. Switch access for people who aren't engaged. Well, it's important to identify what we think is the cause of why why this client is not engaged. Is it cognitive? Is it that I'm not motivated? Is it white coat syndrome? What's going on? Vision. And then we need to establish rapport. That can take some work, but it's important. If that means that I need to know all the latest songs from the latest kid movie, then that's what I need to know. If I need to know that this client likes Paw Patrol and what's the name of some of those characters, and that's what I need to know. I need to find what motivates this client as well and be willing to incorporate that into whatever I'm doing. And then from there, try to find the best switch type and best placement for that individual and help them see this as a tool, not as the task. And that requires a lot of patience and a lot of time, not just on our part, but the whole team, including the client and the caregivers, explaining to them why this investment of time could be very beneficial for the individual in the long run. So again, I want to open this up for any questions. And while you're typing in any questions or comments, I do want to thank you for your time for today. I know your time is very valuable and make sure you have my contact information as well. So again, any questions or comments, feel free to type those on into the Q&A box. I'm happy to address anything you want to talk about. We have a few more minutes here at the end. We also in the library have a course on switch assessment for people who have increased muscle tone and switch assessment for people who have muscle weakness, because our strategies, the switch types that we often consider in switch locations can be different with those populations. So hopefully those will be helpful to you as well. Boy, yeah, usually with this group, I've got more questions than I can handle. It doesn't sound like we have quite as many today. Maybe it's because I answered all of your questions so well during the course. That would be great. I hope so. But I can hang on here a few more minutes. Why don't we have Jim, if you have anything you need to let people know as we wrap up, then if people type in any questions or comments while you do that, there we go. Then I can go ahead and answer those. So why don't I answer this question, Jim, and I'll let you take us on out. Monica has asked, can you recommend a joystick mouse mover that can be held with the whole hand? I believe it's whole hand there. A joystick mouse mover. If you mean a computer mouse that's shaped like a joystick, there's really only one on the market, and it is distributed by AbleNet, and it's called the Rock, and it has several different handles that are available, including round and one that's like a T shape. So it is a USB mouse, but it's the main one I'm aware of. It has recessed buttons for click and double click and such, so that the client's not as likely to bump into those accidentally. They can let go and then click. And if those buttons don't work for the client, you can plug in a separate switch and use it that way as well. If the client is driving a power wheelchair and they're really good with that joystick, then they can also use that on our complex rehab power chairs with Bluetooth emulation to emulate a mouse. Christian has asked, does it have a scroll feature? I do not believe that the Rock does. That is a more difficult feature. I think it just has, well, I'd have to think about that one. And Jim, feel free to type in an answer or unmute yourself. It has lock, so that you can do a drag feature, and it has left click, double click, and I think right click, but not scroll. Jim, do you know if there's any other click features that the Rock has?
I actually don't. I'm not familiar with that product.
Okay, yeah, no problem. But you can look it up on the AbleNet website. There'll be more info. Great.
All right. Well, thanks, Michelle, for a wonderful presentation.
Thank
For those
you.
of you still with us and asking questions about certificates and handouts, there will be an email going out tomorrow with links to the handout again, a link to get the certificate of attendance. And you can always feel free to email me. You should have received that reminder email. It's got my email address in it, jlarocco, LAROCCO, @ablenetinc.com. You can always just contact customer service as well, and they'll send it over to me. All right. Thank you,
Great.
everyone, for attending. Michelle, thanks again for presenting.
Thanks, everyone. And yep, no more questions. Okay, I saw one more. Thanks, everyone.